you so much. First and foremost, I am very thankful to the entire team, especially to my dear friend Mahoj Pahukar, who has given me this opportunity. So, to get on with the topic and to set the ball rolling, we are discussing today something of utmost importance because when the patient comes, our first interaction with the patient is in OPD. And as they say, the first impression is the last impression. I would say that first impression may not be the last impression, but it is still the lasting impression. So in this day and age, when quite a few of our patients come with a lot of preconceived notion and prejudices, and the internet and the Google doesn't helping matters, it is very important to interact with our patient in a nice way and to make them understand their problem in a very positive atmosphere. I have stressed the word positive atmosphere. Right. So going ahead. Yes. So OPD counseling is basically A, B, and C. A, of course, is the appearance and the dress code. B is our body language. to, if you look at the cartoon on the right, we can impress the patient with a lot of medical gobbledygook, but that doesn't really help. So if we talk of appearance, there's a picture on our left and there's another one on our right. On our left, what we can see are two of our harried colleagues, and that is the most common scenario in a populous country where the patient doctor ratio is really very poor. And they, in spite of putting their best foot forward, they are not able to really be very positive. If we look on the right side, look at the picture of the face, a smiling face, a nicely combed hair, a good tie, and a good dress with a good ambience. So that is the appearance of the OPD, which sets the ball rolling in a positive sort of manner. So appearance is of utmost importance. Body language. Now, body language, we can speak and communicate ourselves, but before we start speaking, the patient, any other person, looks at us, and what we say from our body, from our looks, from our hand, what we say matters a lot. Look at the picture on your left. There's a big line. People are disinterested. Many of the patients are looking at some other direction. The doctor is busy looking, pouring into his book or his copy or his prescription. He may be very worried about the number of patients that he has to see. On the right, you can see a doctor with an open hand looking right into the eyes of the patient, smiling. So the body language on the right is what is desirable. So we have to strive for a body language which is positive, which is communicative, which shows the patient that yes, we care. Now coming to communication, these are a few things that I have noted down and I'll try to explain them one by one. The first thing is when the patient comes, he generally comes with a lot of anxiety and fear. We have to be positive. We have to put things in right perspective, and basically we have to allay the anxiety and fear. That doesn't mean that we have to paint a rosy picture, but we have to put things in a right perspective because the glass can be half empty. It can also be called half full. So our attitude should be half full rather than be half empty, and let the patient not become a nervous wreck. So a positive language, a positive body language, and a positive appearance adds to the effect of allaying the anxiety and the fear of the patient, and the patient may feel better. And a happy patient recovers well, we all know. Yes, listening is, as it is important to speak, similarly it is important, probably even more important, to be a good listener. So who is a good listener? Where the eyes are watching, you're all ears. You are giving the patient, you're turning towards the patient side, giving him your full attention. We are not endeavoring to say something, so our lips are closed, hand are still, so hand are not fidgeting. We are positive. We are all ears. So be a good listener. Keep our feet silent, no foot tapping, and anything of the sort, and be a good listener. And another thing, it is said that the most important sound to any person on earth is that of his name. So while interacting with a patient, it is good to be present to the patient and call him or her by name. We have to put a little effort in looking up into the prescription and trying to remember name. So whenever we speak to the person, we speak by name and thereby adding a personal touch. Yes, the other point that I feel is very important is be empathetic and not sympathetic. So what is the difference? Sympathetic is when you put yourself on a pedestal and say, okay, all right, we can understand you are in a problem. But being empathetic is feeling his fear, feeling his concern, and sharing his pain. So that is what the cartoon says, that we have to be empathetic, not sympathetic. Yes. And yes, patient may come and they may ask all kind of silly questions. So no question is silly in the OPD consultation. The patient may ask and pour his heart out, and in the process may ask something very silly as well. And we have to really be very, empathetic, that I said. We do not need to frown and not make fun in any sort of way. Other thing, we don't have to instill any kind of fear in patient's mind. You see, a problem, when painted out of proportion, will become very big, very problematic, like a life-threatening problem. It will become life-threatening problem. So we have to keep ourselves away from this tendency. And no, do not hurry. We can be quick, we can be efficient, but we need not be hurrying while seeing the patient. Other thing, we have to explain to the patient the treatment, but no need to overdo it. No need to put so many ifs and buts. No need to put so many rarest of rare complication. We have to be realistic, but let's not overdo it. And then, last but not the least, we have to give our patients some time, some space. They can go back. We do not have to sell our surgery. Like in a joint replacement surgery, we do not have to sell it. Let them earn it. Let them ask for it. We can suggest everything and give the patient time, a space, so that he can go and think over it, mull over it, and come back and ask for it. Yes, that is the stark reality of our country. It is overcrowded with patients. This picture I have taken from Times of India, where an IPD, an inpatient area of patient is shown in what is the picture in most of the medical colleges in crowded areas. But still, we need to have a heart and be good to our patient and give them a very positive overall experience. Therefore, thank you so much. Have a great day, great week, month, and a wonderful 2021 ahead. Thank you so much. Thank you.
Thank you, Shantanu. That was a wonderful lecture, and with pertinent tips of looking into the eyes of patient and having a counseling session. That was really great. Manoj, do you have any questions for Shantanu? Unmute yourself, Manoj. Manoj, you are. It seems you are muted. Rajiv Raj, you wanted to say something? Yes.
Yeah, fantastic presentation for initial.
Well, I think probably looking into the eye.
Hello.
Looking into the eye,
yeah,
can be a very cultural thing.
Yes.
You see, there were people who were arrested in the US after the 9/11 attack, the Twin Tower attack. These were Arabs. And the case in the court was they did not look into the eyes of the investigators, so probably they were guilty. While these Arabs said, in our culture, authority is authority. We can't look into the eyes of an authority. We are always taught to look down. So probably we have to have a very measured way, look a little, leave a little, look a little, because if it's a beautiful girl, and Shantanu, if you are staring at her, her husband will have your neck in your hand.
So, although I will probably not help staring, but there is a difference in staring and looking into the eyes. We can look gently with a crinkle in our eyes. So I never mean to be staring at my patient, but looking at her gently in a reassuring way. That's what I meant. Thank you, sir.
Yeah. Any on this point, any input from Dr. Madan Kapre, sir?
No, that's fine. I will have something to say when I talk in the next
Okay, perfect.
If there are two options that you can provide to a patient. Like if there is a humerus shaft fracture, you can treat it conservatively, you can operate it. So how do you counsel them? Do you give them options, or do you tell your preference, or do you decide for them?
Yes, that's a very good question. As far as shaft humerus fracture is concerned, I'll definitely, in most of my patients, I give a picture of conservative therapy as well as a picture of operative therapy. We also have to look at the patient. If the patient is elderly and the shaft fracture is comminuted and the patient is very hefty and there's a big fatty arm, so we really cannot treat that patient in conservative manner. Whereas a transverse fracture, which is a stable, which can have a stable reduction in a suitably, not, I will not say lean and thin, but a physically appropriate patient can be treated. Other matters are like availability of money and other things. So we have to say and give the patient a correct picture. So I always give the patient a correct picture, also suggesting. Sometimes they will ask me, what do you think is right for me? Then I very gently say, this is what I think, and this is what you should do. So your sincerity and your honesty comes across to the patient, and they make their own decision, taking your good advice into account. Thank you so much.
Thank you, Shantanu. Jawahar Jetwa sir would like to comment on this topic, conservative versus surgical.
I just wanted to say regarding the gesture, I mean the body language.
Yes, sir.
It's very important, but you get feedback from your staff or from your friend or somebody who is not a patient. We forget to get feedback whether my body language was good or bad. We never take a video of our own. You know, like singing a song, you always take a rehearsal and you listen yourself to improve. So very important thing is that sometimes some bad habits, some bad gestures, they remain whole life, and you have never taken a pain to correct it because you have no feedback accepted. So that is something very important.
Yes, sir.
Let us listen to Dr. Gurva Reddy for this. Dr. Gurva, can you please make your video on?
Yes, sir.
Yeah.
It's very, of course, a lot of the things will be repeated in the next slide also.
Yeah.
I got a one or two very personalized way of getting into the patient psyche, because you cannot expect a patient to take a decision.
Your net,
you got to lay the things on the table. End of the day, when the patient says to me, I would say, if she is my mother, I would operate.
Okay.
That is a very standard, emotionally very powerful phrase.
Okay.
And because a lot of the times I don't do trauma, but my people do. A lot of people come to me for a trauma referrals. Then I would say 80-year-old, 90-year-old, they say that, sir, the patient ka to, there are complications. Then I say, I would rather get my mother dead on the operating table than on the bed with bed sores, pneumonia, and all this stuff. That is a very powerful statement. A lot of the patients take that.
Okay, perfect. Ashish, you would like to comment on conservative versus surgical options? How do you convince, how do you tell them the scientific way?
Yeah, so I agree with Dr. Reddy, and basically our confidence in the procedure passes on to the patient, and the patient can sense that. So even if we are trying to extend that indication and we are on shaky grounds, the patient can sense that ye convincing lagta nahi hai, and then they will go for a second opinion. That is what happens. So I think looking into the patient's eyes and giving him that empathy rather than a sympathy ki arey tumhara tood gaya hai, and now you're going to be out of a job for 1 month. And
yeah, Ashish has got a very relevant point. The last thing you can do to yourself in a negative way is not to be certain in front of the patient. If you are not assertive, even if you are bluffing, you should be assertive. The patient should get that confidence. This guy he knows what he's doing. I have seen some consultants, they talk for half an hour. End of the half an hour, the patient doesn't get that feel that this guy knows something. So they are very uncertain. So that's not the way to go.
No, I fully agree. I fully agree. That's why I said that it need not be overdone. It has to be done to the right amount only.
Yeah, okay, of course.
Yeah,
That is
yes.
the key.
Yeah.
Right amount, wrong amount, and optimization is entirely subjective, depending on your personality, patient's personality, the surrounding things. Let us say if the patient is a mother-in-law of a cardiologist friend of yours, your approach will be entirely different.
Yes.
That-
Very, very dynamic, very dynamic.
Yes. Yeah. Thank you. Thank you very much for those inputs. Now let us move on to the next lecture. Now I invite Dr.